Welcome to the Deep Dive. Today, we're taking a close look at a condition you really need to know about: Stevens-Johnson syndrome, or SJS. If you're in medicine, especially if you're prepping for something like the MSRA exam, this is definitely high-yield stuff. It demands your attention because while it's rare, it's incredibly serious.
That's absolutely right. Our aim here is really to, cut through the complexity and pull out the essential knowledge on SJS,
Right.
what it is, why it happens, how to spot it, how it's managed, and what the potential outcomes are. Think of this as your focused, efficient revision session.
Perfect. Yeah, it's one of those diagnoses that when you see it, you need to act fast. So let's dive right in and unpack what SJS is, at its core.
Okay. Fundamentally, Stevens-Johnson syndrome is a severe, life-threatening reaction. It primarily affects the skin and the mucous membranes. It's rare, but when it hits hard.
So what are the defining features then? What makes it stand out from other rashes or reactions?
Well, the hallmarks are a widespread blistering rash, and this is crucial, significant involvement of the body's mucous membranes.
Right.
And almost always, this is triggered by something external, most commonly medications or sometimes infections.
So it's not just affecting the skin then. Where else does it show up?
Oh, definitely not just the skin surface. It involves mucous membranes pretty much everywhere: the mouth, the eyes, the digestive tract, genitals, respiratory tract.
Wow.
Yeah, this widespread involvement is why it can rapidly lead to systemic complications and even multi-organ failure.
That multi-system impact really underscores how serious it is. How common are we talking globally or, specifically in the UK?
In the UK, we're looking at an incidence of roughly 1 to 2 cases per million people per year. So yes, it's rare.
Very rare.
Very rare. And the mortality rate for SJS itself is less than 10%. But that statistic doesn't tell the whole story because survivors often face significant long-term health issues.
Okay. And how do doctors classify this condition? Is it like a straightforward allergic reaction?
It's definitely more complex than a simple allergy. It's classified as an immune complex-mediated hypersensitivity disorder.
Right.
What's really critical to understand is that SJS is actually part of a spectrum of severity. At the milder end, you might see things that overlap with erythema multiforme, and at the most severe end, you have toxic epidermal necrolysis, or TEN.
Okay, so SJS and TEN are sort of on the same continuum?
Exactly. They stem from the same core problem, a process where the top layer of skin, the epidermis, and also the mucous membranes, they start to detach from the layers underneath.
Okay.
The distinction between SJS, SJS-TEN overlap, and TEN is mainly based on the percentage of body surface area where that detachment is happening, and also the type of skin lesions you see.
Can you just quickly clarify those categories based on detachment? That sounds like a key differentiator.
Sure. So when the detachment is less than 10% of the body surface area, and you primarily see these sort of raised, atypical, target-like lesions, that's typically SJS.
Okay, 10%.
Yeah. If the detachment is between 10% and 30%, it's classified as SJS-TEN overlap.
Got it.
Once you get above 30% detachment, pretty much regardless of the lesion type, you're in the realm of toxic epidermal necrolysis, or TEN.
Right. 10 is 30%.
Exactly. And there's also erythema multiforme major, which is often considered part of this group, less than 10% detachment, but different lesion types, often more classic targets.
Got it. So it's really about the scale of that detachment. Now, what actually triggers this devastating immune system response?
Well, the primary drivers are indeed the body's immune system overreacting to specific external agents, most commonly medications or, in some cases, infections. We also know genetics play a pretty significant role in determining who might react this way.
Okay, let's talk medications. Which ones are the most notorious culprits, the ones someone revising really needs to remember?
Yeah, this is definitely high-yield information. The big categories include antibiotics, particularly the sulfa drugs like sulfamethoxazole.
Sulfa drugs.
Yep. Anticonvulsants are another major group. Think carbamazepine, lamotrigine, phenobarbital, phenytoin.
Okay.
NSAIDs, especially the oxycam class like meloxicam, they're linked. Allopurinol is a really well-known trigger.
Allopurinol, right.
Antivirals like nevirapine and abacavir are also significant. And then, less commonly, things like sertraline, bupropion, certain antifungals, and salicylates can be involved too.
That's quite a list of common drugs. What about infections?
Infections are also triggers, yeah, but there's a bit of a pattern, especially with children. In kids, viral infections are more frequent culprits. Things like influenza, mumps, measles, herpes simplex, Epstein-Barr virus.
Right.
In adults, while infections like Mycoplasma pneumonia, HSV, HIV, or group A strep can trigger it, unpredictable drug reactions are more often the cause. There's also an association noted with some immunizations like measles and hepatitis B.
So when you see a patient presenting with the signs, a really meticulous drug history, looking for anything new they've started, is absolutely essential.
It's arguably the single most important question you can ask initially. Have they started any new medication, prescription or over-the-counter, or had a recent infection? Thinking about those key drug categories we just mentioned can help narrow down the possibilities pretty quickly.
Makes sense. Beyond the trigger itself, who is most at risk of developing SJS if they are exposed?
Yeah, certain patient populations definitely have a higher propensity. Those with underlying viral infections, particularly HIV individuals with HIV, have a significantly higher risk of developing SJS-TEN compared to the general population.
Wow, really?
Yeah. Other immunocompromised states also increase risk, like patients undergoing chemotherapy, organ transplant recipients, or those with autoimmune diseases like SLE.
And does a person's past history or family history matter?
Yes, big time. If you've had SJS before, especially linked to a specific medication, you have a much higher risk of it happening again if you're ever re-exposed to that drug.
Right. Avoid it for life.
Exactly. And having a family history of SJS can also suggest an increased genetic susceptibility.
Genetics. This is where those HLA types come in, isn't it?
Exactly. This is a fascinating piece of the puzzle. Specific human leukocyte antigen, or HLA, alleles are strongly linked to SJS triggered by certain drugs, often in specific populations.
Like which ones?
For instance, in people of Han Chinese origin, the HLA-B1502 allele is strongly associated with carbamazepine-induced SJS.
Okay.
HLA-B1508 is linked to allopurinol-induced SJS, and HLA-B5701 is associated with abacavir-induced SJS-TEN, particularly in HIV patients.
So is this genetic link why sometimes screening is recommended before prescribing certain drugs?
Precisely. In populations known to have a higher prevalence of these specific HLA alleles, screening patients before starting medications like carbamazepine or abacavir can be a vital preventative measure to avoid potentially triggering SJS.
Right. Let's switch gears slightly and talk about what's actually happening inside the body. The pathophysiology, how does this immune attack unfold at like a cellular level?
Okay. Think of your immune system as your body's security system, constantly patrolling for threats. In SJS, that system gets confused. It mistakenly identifies your own skin and mucous membrane cells as foreign invaders and launches a massive attack against them.
Like friendly fire.
Exactly, but on a devastating scale. It's an immune-mediated process involving a complex interplay of that genetic background, activation of immune cells, and the presence of the triggering drug or infection.
Okay.
This leads to an inflammatory cascade, which basically signals the skin cells, the keratinocytes, to undergo programmed cell death, or apoptosis.
So the cells essentially self-destruct.
That's the outcome. And as these skin cells die off, the connections holding the epidermis to the underlying layers break down. This causes that top layer to detach, much like, well, like wallpaper peeling off a damp wall,
Okay.
resulting in those characteristic blisters and raw, painful erosions.
Wow. Thinking of it like peeling wallpaper is a vivid, if slightly terrifying, analogy. Given how it presents with rash and blistering, I imagine there's a long list of other conditions it could be mistaken for, especially early on. What are the key differential diagnoses?
Yeah, this is absolutely crucial for anyone needing to diagnose this, especially under pressure, because SJS can look like many other things. You need to consider a whole range of possibilities.
Right.
Of course, toxic epidermal necrolysis, TEN, is top of the list, being part of the same spectrum. But you also need to think about things like erythema multiforme, especially EM major, acute generalized xanthomatous pustulosis, or AGP, autoimmune conditions like bullous pemphigoid or pemphigus vulgaris, severe reactions that can look similar, like bullous phototoxic reactions or exfoliative dermatitis, sometimes called erythroderma, even infections that cause skin issues, like staphylococcal scalded skin syndrome, SSS, which is really important to distinguish because it's bacterial and needs different treatment, even rarely Lyme disease. And of course, simple maculopapular drug rashes, though they usually don't have that severe blistering and mucosal involvement.
That's quite a challenging list.
It is. Distinguishing SJS from these, particularly TEN and erythema multiforme, is vital because the management and prognosis really differ.
Okay, so just a quick recap on the numbers before we move to presentation. We mentioned the UK incidence, but are there any other key epidemiology points?
Just to reiterate, yeah, it's 1 to 2 cases per million per year in the UK. It is generally more common in adults, with perhaps a slight female predominance.
Right.
But the most significant risk factor from an epidemiological standpoint is undoubtedly HIV infection, which increases the risk substantially.
Okay.
And while it can occur at any age, most patients are between 10 and 30 years old. Younger children who do get it tend to have a higher mortality risk.
Okay, let's get into the clinical picture then. How does SJS actually present? What would a patient complain of, and what would a doctor see?
Right. It typically doesn't start with the full-blown rash. Often the initial symptoms are quite nonspecific, almost like a bad case of the flu.
Like a prodrome.
Exactly, a prodrome. Patients might feel generally unwell, have a fever, sore throat, chills, headache, joint pain, maybe some nausea, vomiting, or diarrhea. This phase can last a few days.
So it could be easily missed initially.
Yes, the prodromal phase can be tricky, but then things progress rapidly. The mucocutaneous lesions develop quite suddenly, and a key point is they're usually not itchy, which helps differentiate them from common allergic rashes.
Not itchy.
Okay.
Describe the skin lesions themselves.
They can start anywhere on the body, but often begin on the trunk and proximal limbs, sometimes involving palms and soles early on. They might start as flat red areas, macules, or slightly raised bumps, papules, that can then develop vesicles or bullae, those large blisters. Right. A characteristic but sometimes misleading feature is target-like lesions, although in SJS itself, they're more often described as atypical targets, less well-defined, maybe dusky centers. These blisters then rupture, leaving raw, painful areas that look a bit like superficial burns and are really prone to infection.
And there's one physical sign that is a massive red flag for this condition in 10, right?
Yes. It's called the positive Nikolsky sign.
Ah, the Nikolsky sign.
Yeah.
What is it exactly?
It's when you apply minimal pressure or gentle friction to seemingly unaffected skin near a lesion, and the epidermis, the top layer, blisters or peels away easily.
Wow.
This sign indicates that there is underlying epidermal detachment, which is the absolute hallmark of SJS-TEN. If you elicit a positive Nikolsky sign in a patient with a widespread rash, you should be thinking SJS-TEN immediately.
That sounds incredibly painful and also like a crucial diagnostic clue.
Yeah.
You mentioned mucosal involvement is key. What does that look like in practice?
Yeah, it's almost universal and often precedes or occurs simultaneously with the skin rash. It involves redness, swelling, blistering, ulceration, and actual tissue death necrolysis of the lining of multiple body cavities. The mouth is almost always affected, with severe, painful erosions that make eating, drinking, even talking incredibly difficult.
Right.
The eyes are also very frequently involved, causing painful red eyes, significant discharge, sensitivity to light, photophobia, and inflammation of the eyelids and conjunctiva. Genital involvement is common, leading to painful urination, dysuria, or difficulty voiding. And the lining of the respiratory and gastrointestinal tracts can also be affected, leading to cough, difficulty breathing, or severe diarrhea.
So it's truly attacking the internal linings as well as the external skin.
Absolutely. That widespread epithelial surface involvement is what drives many of the severe complications.
Okay, let's try and put some of this together into a potential scenario, maybe someone prepping for an exam might see. Imagine a 25-year-old patient presents to ED. They felt unwell for a few days with fever and joint aches. Yesterday, they started developing painful red areas on their body that are now blistering, and they have excruciating sores in their mouth that are bleeding, and their eyes are red and sensitive to light. On examining their skin, you notice the top layer seems fragile and easily peels off with gentle rubbing. What's the most likely diagnosis, and what's that physical sign you just elicited?
Okay. That presentation with the prodromal symptoms, the painful blistering rash, the severe multi-site mucosal involvement, and that skin fragility.
Yeah, that screams Stevens-Johnson syndrome or 10N.
Right.
And that physical sign, the skin peeling away with gentle pressure, that's the positive Nikolsky sign. Recognizing that pattern quickly is paramount.
Right. So presentation is key for diagnosis, but are there investigations to confirm it or assess the severity?
Yes, absolutely. SJS is primarily a clinical diagnosis based on those characteristic features we just discussed.
Yeah.
But investigations are essential to support the diagnosis, gauge how severe it is, and help rule out some of those look-alike conditions we mentioned earlier.
What are the core tests needed? You'll need a range of blood tests, definitely a full blood count, inflammatory markers like ESR and CRP, kidney and liver function tests, UNEs, LFTs, electrolytes, coagulation studies. Serology for Mycoplasma pneumonia might be sent if that's suspected as a trigger.
Okay.
A chest x-ray is usually performed. Clinical photographs are vital for monitoring progression, and swabs from skin lesions or mucosal sites should be taken for bacterial and fungal cultures to check for secondary infections.
And how about a skin biopsy? Is that necessary?
A skin biopsy is very important for confirming the diagnosis, particularly in less clear-cut cases, or to rule out differentials like autoimmune blistering diseases.
Right.
The biopsy needs to be taken from an affected area and, crucially, sent unfixed for direct immunofluorescence studies, DIF, which can help differentiate it from other blistering conditions.
Unfixed for DIF, got it.
Exactly. The histology typically shows programmed cell death in the basal layer of the epidermis, blistering just below the epidermis, and some inflammatory cells.
Is there a scoring system to predict how unwell a patient might get?
Yes, there's a widely used prognostic score called SJS-TEN, or Score for Toxic Epidermal Necrolysis. SJS-TEN. It's calculated within the first 24 hours of hospital admission using 7 clinical and laboratory parameters. A higher SJS-TEN score predicts a higher risk of in-hospital mortality.
Okay.
It's a crucial tool for prognosis and really helps guide the intensity of management required, indicating who needs, burn unit or intensive care level support.
So, diagnosis made, assessment done with SJS-TEN. What is the management? This sounds like it requires immediate intensive care.
It is absolutely a medical emergency requiring immediate hospitalization, ideally in a specialized unit, like a burns unit or intensive care unit.
Right.
Because the complexity and supportive care needs are very much like managing a severe burn. A multidisciplinary team is essential.
What is the single most important non-negotiable initial step in management?
The absolute priority, the very first thing you must do is immediately discontinue any suspected causative drug.
Right. Stop the drug.
If a medication is the likely trigger, stopping it is critical and directly impacts the outcome.
Okay, drug stopped. What comes next in terms of supportive care?
Initial management focuses heavily on meticulous supportive care. This includes establishing IV access, aggressive fluid resuscitation to replace the large volume losses from the damaged skin and mucosa seriously. Think like managing severe burns in terms of fluid loss.
Okay.
You need to closely monitor fluid balance. Nutritional support is vital. Because of the severe oral involvement, patients often can't eat, so a nasogastric tube is usually required.
Makes sense.
A urinary catheter is needed if there's genitourinary involvement. You also need to estimate the body surface area affected, just like with a burn patient, as this helps guide fluid management and prognosis.
And for symptom relief, particularly the pain, which must be immense.
The pain is immense. Strong analgesia is crucial. For the mouth, anesthetic or antiseptic mouthwashes can provide some relief. Skincare involves gentle cleansing, application of emollients, and antimicrobial agents to prevent secondary infection. Eye drops and ointments are essential for ocular care, often needing involvement from ophthalmology early on.
I've heard debate around the use of systemic corticosteroids or other immunosuppressants. What's the current thinking on that?
That's right. The use of systemic corticosteroids and other immunomodulatory therapies like IVIG is controversial.
Yeah.
While they might seem logical to dampen the immune response, they also carry significant risks, particularly increasing the risk of overwhelming infection in patients who already have compromised skin barriers and are often critically ill.
Right, makes sense.
So management is increasingly focused on that meticulous supportive care rather than systemic immunomodulation, though specialist advice is always needed.
And looking ahead, once a patient recovers, how do you prevent this from happening again?
Crucial prevention. If a causative drug was identified, the patient must be advised to avoid that medication for life.
For life?
Absolutely. They should be given clear written information about the drug and encouraged to inform any healthcare provider they see. And if genetic links were identified, informing family members about potential susceptibility is also important.
It really does sound like managing a severe burn patient. Intensive supportive care, fluid balance, pain control, infection prevention, nutrition.
That's a very good analogy to keep in mind for the management principles. The damaged skin barrier and the systemic nature create very similar challenges.
Shifting to the outlook then, what's the prognosis for someone who gets SJS?
Well, prognosis varies significantly depending on the severity, particularly the percentage of body surface area involved and how quickly that offending drug is stopped.
Right.
The overall mortality rate is somewhere between 5% and 15%.
Okay.
As we noted earlier, it's maybe up to 10% for SJS itself, but for the more severe 10N, the mortality rate is significantly higher. We're talking at least 30%.
Wow, 30% for 10. And even for survivors, there can be significant long-term issues.
Absolutely. Survival is definitely not always a full return to baseline health. Many survivors face lasting complications.
Like what?
These can include chronic skin problems like scarring, changes in pigmentation, lighter or darker patches, and increased sensitivity. Nail dystrophy, problems with nail growth is common.
Hmm.
Mucosal issues can persist, leading to chronic dryness, erosions, or even strictures in the mouth, esophagus, or genitals. And ocular complications are particularly devastating,
Rags, yes.
ranging from chronic dryness and light sensitivity to corneal ulceration and, in severe cases, permanent visual impairment or even blindness.
That really highlights the potential for severe morbidity even after recovery. What are some of the other potential serious complications that could arise during or after the acute phase?
Yeah, beyond the skin's risk of secondary bacterial infections leading to sepsis, the complications really affect multiple organ systems. Respiratory issues are common and serious, including pneumonia, bronchial obstruction from slop mucosa, and even respiratory failure.
Okay.
Cardiac problems like myocarditis can occur. While less common, acute kidney injury or acute tubular necrosis is a possibility. Mild liver inflammation is sometimes seen. Gastrointestinal involvement can lead to severe diarrhea or long-term esophageal strictures. And the genitourinary and ocular complications we've already highlighted can be severe and chronic.
And the really critical life-threatening ones.
Well, patients are at risk of severe dehydration and malnutrition due to that mucosal involvement. They can develop shock, progress to multi-organ failure, develop blood clots, thromboembolism, or a severe clotting disorder called disseminated intravascular coagulation, or DIC.
DIC, right?
And we can't forget the significant psychological trauma this experience inflicts. Also, the formation of pseudomembranes. These thick, abnormal layers of tissue on damaged mucosal surfaces can lead to scarring and long-term dysfunction in various organs.
It really is a systemic catastrophe triggered by that initial immune reaction.
It truly is. It's a devastating condition affecting epithelial surfaces pretty much throughout the body.
We've covered a lot of ground on Stevens-Johnson syndrome today, defining what it is, exploring its triggers and risk factors, understanding the pathophysiology, recognizing the clinical signs, including that crucial Nikolsky sign, outlining investigations and management, and discussing the challenging prognosis and potential complications.
Yeah, understanding the spectrum of disease, recognizing it early based on the clinical presentation, and knowing that absolute critical initial steps stopping the offending drug is paramount for managing this medical emergency.
We really hope this deep dive has given you a clear, high-yield understanding of Stevens-Johnson syndrome for your revision.
And for more free MSRA revision resources, visit freemsra.com. And for the full premium revision toolkit, head to passthemsra.com.